Welcome to the Deep Dive. Today we're tackling something really important. The clinical practice guidelines from the Society for Vascular Surgery, the SVS.
That's right.
Our mission, to basically take this big stack of expert advice and pull out the absolute must-knows for you. These guidelines aren't just, suggestions. They're designed to standardize care and really improve outcomes for vascular conditions. Think of this as your shortcut to understanding the really vital stuff.
And it's worth stressing, these aren't just pulled out of thin air. They're built by leading vascular surgeons, other specialists, looking at the latest evidence. It really shows how the SVS pushes clinical practice forward and keeps patient safety front and center.
Okay.
And they cover a huge range: aneurysms, peripheral artery disease, you name it. Recommendations on diagnosis, treatment, long-term care. It's all in there.
Right. Okay, let's unpack this then. We're going to walk you through how these guidelines help doctors pinpoint problems, choose the best treatments, and crucially, support long-term health for patients. Kind of a journey from suspicion to, hopefully, lasting well-being.
Sounds good.
So let's start right at the beginning. Diagnosis. How do these SVS guidelines give clinicians the best tools to actually identify vascular conditions accurately?
Well, it's all about precision, using the right test at the right time. Let's take chronic mesenteric ischemia, CMI. That's when the intestines aren't getting enough blood.
Okay.
The guidelines say, look, the diagnosis needs both the right patient symptoms and proof of significant narrowing, like over 70% in those key arteries supplying the gut.
So not just the symptoms alone.
Exactly. And for screening, the go-to is usually a mesenteric duplex ultrasound, a DUS. It's a good first look.
Right.
But for the definitive picture, especially if you're planning an intervention, CT arteriography, or CTA, is preferred.
Why CTA? What makes it better?
It just gives incredible detail. Its accuracy is reported really high, like 95 to 100%. You get this crystal clear view of the anatomy, which is vital for planning surgery or an endovascular procedure. Plus, it helps rule out other things causing chronic belly pain and can even spot signs of bowel ischemia.
Wow, okay. That level of detail is impressive. And I guess that precision carries over to other conditions too,
Yeah.
like problems in the legs, especially with diabetes. Let's talk about chronic limb-threatening ischemia, CLTI, and PA in diabetics.
Absolutely critical area. If
Right.
a patient with diabetes has a foot ulcer or gangrene, you have to assess for peripheral artery disease, PAD.
Right.
So you start with the history, the physical exam, checking foot pulses. But here's the key thing the guidelines stress. Just that clinical exam, it's not enough to confidently rule out PAD.
Why not?
Because sometimes the signs can be subtle or other things can mask it. So the guidelines recommend using pedal-doppler waveforms, listening to the blood flow signals, along with measurements like the Ankle-Brachial Index, ABI, and the Toe-Brachial Index, TBI.
Okay, ABI, TPI. What's the difference there?
Well, this is interesting. The ABI compares blood pressure at the ankle to the arm. But in some patients, especially those with diabetes or older folks, the arteries in the lower leg can get calcified and stiff.
Ah, so they don't compress properly?
Exactly. So the ABI reading can be falsely high, like over 1.4, making it look like the blood flow is fine when it's actually not.
That sounds like a real diagnostic trap.
It can be. That's why in those cases, the guidelines say TBI, or another measure called transcutaneous oxygen pressure, TCPO2, are mandatory. They give you a much truer picture of the actual perfusion down in the foot. It's a crucial safeguard.
Got it. So the guidelines build in checks to avoid being misled. Now, you mentioned something called the WIFI system earlier. How does that fit in?
Yes, the SVS WIFI classification system. It stands for wound, ischemia, and foot infection. It's a super important tool for stratifying risk in patients whose limbs are threatened.
So it standardizes how you assess the threat.
Precisely. It grades each of those three things: the wound, the lack of blood flow or ischemia, and any infection on a scale, usually 0 to 3.
Okay.
So the wound grade looks at size, depth, how severe it is. Is it minor tissue loss, or is it extensive, maybe needing a major amputation? The ischemia grade is based on those perfusion measures like ABI or TBI. A grade 3 might mean an ABI below 0.4, really high risk. Infection grade looks for signs like cellulitis, spreading redness, or deeper issues like bone infection, osteomyelitis. It creates a common language.
That makes sense. Can you give us a quick example just to see how it works in practice?
Sure. Let's say you have a patient with ischemic rest pain, that's severe pain even without activity, but no wound, no infection. Their ABI is maybe 0.30.
Okay.
They might be classified as WIFI 030, 0 for wound, 3 for severe ischemia, 0 for infection.
Simple enough. What about a more complex one?
Okay, imagine a 55-year-old with diabetes. They have dry gangrene on 2 toes, a bit of cellulitis around it. You can't feel their pedal pulses. Their ABI is, say, 1.5, falsely high, right?
Right, because of the calcification.
Exactly. But their toe pressure is low, maybe 35 millimol Hg. This patient could be a WIFI 221. Grade 2 wound, grade 2 ischemia based on the toe pressure, grade 1 infection. It immediately tells you it's a more complex, urgent situation.
That WIFI system really does clarify the picture. Okay, so we've got these detailed tools for complex limb issues. What about more common things like varicose veins or aneurysms?
Yeah, the guidelines cover those too. For varicose veins that are causing symptoms and have come back after previous treatment, you definitely need a clinical evaluation and that duplex ultrasound, DUS, before doing anything else. You need to know why they came back.
Makes sense. Find the source.
But interestingly, there's the SVS Choosing Wisely initiative. It specifically advises against doing routine venous ultrasounds on patients who just have cosmetic spider veins, C1 veins with no symptoms.
Why is that?
To avoid unnecessary tests that might lead to unnecessary procedures, it's about appropriate use.
Smart. And for abdominal aortic aneurysms, AAAs.
Ultrasound is excellent for screening and for surveillance, watching them over time. It's accurate and safe. But if you're planning a procedure, CT imaging gives much better detail for the planning, even though it can sometimes make the aneurysm look slightly bigger than on ultrasound.
Okay. And those other aneurysms, the visceral ones?
Yeah, visceral artery aneurysms in arteries to the gut organs. For ones in the smaller intestinal arteries, like jejunal or ileal, CTA is, again, the diagnostic tool of choice.
Okay, so I've covered getting the diagnosis right. Now, the next big step, treatment. This is where it gets really interesting, doesn't it? How do the guidelines help steer those decisions when there are often multiple paths?
This is absolutely key, and the guidelines start with foundational principle, shared decision-making.
Meaning the patient is central to the choice.
Exactly. For conditions like CMI, but really it applies across the board. The choice of treatment must be a conversation between the patient and the provider. You have to weigh the risks, the benefits, what the patient wants, their goals, their values. It's not just the doctor deciding.
That's so important. Okay, so once you've had that conversation, you often face this choice. Endovascular, less invasive through the blood vessels, or traditional open surgery. How do the guidelines help navigate that?
It often comes down to balancing, how invasive the procedure is versus how long it's likely to last, and considering the patient's overall health. For CMI, for example, endovascular repair using balloons, stents inside the vessel is often recommended first if the blockage looks suitable.
Why start there?
Generally, it means fewer complications right around the procedure, shorter hospital stays, maybe lower initial costs, but there's a trade-off.
Ah, okay. What's the catch?
The trade-off is potentially higher rates of symptoms coming back later and maybe needing more procedures down the road.
Right. So when would open surgery be better for CMI?
Open surgery is usually kept for blockages that just aren't good for an endovascular approach, or if endovascular attempts have failed. Or sometimes in younger, healthier patients where the potential for a much longer-lasting repair might outweigh the bigger upfront risks of open surgery.
Okay, that makes sense. What about for CLTI, the limb-threatening ischemia? Similar logic.
Similar principles, but tailored to limb threat. Endovascular is often considered for high-risk patients whose limb threat is sort of intermediate. I think WI5 stages 2 and 3, maybe ischemia grade 1, especially if a wound isn't healing despite good care.
Trying the less invasive route first in sicker patients.
Kind of, yeah. Open surgery, like a bypass, might be considered for patients with really advanced limb threat, WIFI stage 3 or 4, severe perfusion deficits, or very complex blockages, what we call glass stage 3, or maybe if endovascular attempts have already failed. It's really matching the intervention intensity to the patient's risk and the disease complexity.
That tailored approach seems to be a real theme. What about those varicose veins again, if they need treatment?
Right. If you have symptomatic recurrent varicose veins because the main surface vein, the great saphenous vein, or GSV, is still allowing blood to flow backward reflux, then both open surgery or endovascular techniques can work well.
Any preference?
Interestingly, for large saphenous veins, say over 10 millimeters, the guidelines recommend thermal ablation using heat, like laser, EVLA, or radiofrequency, RFA, over the non-thermal techniques like glue or foam.
Okay. And aneurysms.
Yeah.
Those popliteal ones behind the knee, or the visceral ones.
For popliteal artery aneurysms, or PAAs, elective repair is generally recommended once they reach about 20 millimeters, or sometimes even smaller if there are other risky features like a blood clot inside or poor outflow arteries in the lower leg.
Why fix them electively?
Because the outcomes, especially limb salvage, are much, much better than if you wait for an emergency, like the aneurysm clotting off suddenly.
Proactive treatment saves limbs.
Got it.
And the visceral ones.
Visceral artery aneurysms, VAAs.
Hmm.
Many of these need intervention because of the risk of rupture, which can be catastrophic. This is especially true for pseudoaneurysms, which aren't true expansions of the wall, and mycotic or infected aneurysms, and even many larger true aneurysms. Splenic artery pseudoaneurysms, for instance, are known to rupture more easily and grow quickly, so the recommendation is often to treat them early, regardless of the size. For others, like hepatic artery aneurysms, size matters. Maybe repair over 2 centimeters in low-risk patients, but maybe wait until 5 centimeters in high-risk patients if open surgery is planned. Endovascular options might follow similar size criteria if the blood supply is good. It's complex risk assessment.
It really sounds like it. Okay, so we've identified the problem, chosen a treatment. What about the long game? Long-term health, preventing future issues. It can't just end with the procedure, right?
Absolutely not. That long-term perspective is woven throughout the guidelines. A huge piece is post-procedure surveillance.
Keeping an eye on things.
Exactly. For instance, after someone gets a vein bypass graft in their leg, the guidelines recommend regular checkups, including a clinical exam, ABI measurement, and that duplex ultrasound, DUS.
How often?
Typically, you get a baseline early on, then checks at 3, 6, and 12 months in the first year, and at least once a year after that.
Why so frequently?
Because these grafts can develop narrowings or other problems, and DUS is pretty good at picking them up early, relatively cheaply and safely, allowing for intervention before the graft fails completely.
Makes sense. What about after aneurysm repairs?
Similar idea. After popliteal aneurysm repair, you need regular follow-up with exams, ABI, and DUS to monitor the repair, and also check if the original aneurysm sac is shrinking or, concerningly, growing.
Yeah.
And for bigger repairs, like after thoracic endovascular aortic repair TVAR, for the aorta in the chest, ongoing CT scanning is crucial. Late complications can pop up years later, so the benefit of catching those usually outweighs the risks from the radiation over time.
Right.
And even after less invasive things like embolization for visceral aneurysms where coils or plugs are used, you still need ultrasound or CT follow-up because there's a risk the aneurysm could reopen or recanalize.
So vigilance is key.
Yeah.
Beyond just watching the repair site, what about managing the underlying risks?
Lifestyle. Hugely important. The guidelines hammer this home. For anyone with suspected CLTI, for instance, you have to evaluate and manage their cardiovascular risk factors aggressively.
Like what?
Well, antiplatelet drugs like aspirin or clopidogrel are strongly recommended for pretty much all symptomatic PAD patients. They reduce the risk of heart attack, stroke.
Okay.
And for high-risk CLTI patients, high-intensity statin therapy to lower cholesterol is also recommended. And then there are the big lifestyle factors. Smoking cessation is strongly pushed for AAA patients. It directly reduces the risk of the aneurysm growing or rupturing.
That seems fundamental.
It is. It's about empowering patients to take control of factors that impact their vascular health long-term.
We talked about diabetes earlier. How do the guidelines address the specific long-term challenges with diabetic foot problems?
Yeah, diabetic foot care is a major focus. A key recommendation is using a multidisciplinary team approach.
Meaning lots of different specialists working together?
Exactly. Podiatrists, vascular surgeons, infectious disease docs, endocrinologists. It's recognized as best practice for patients with diabetes, PAD, and a foot ulcer or gangrene. Integrated care leads to better outcomes.
Okay.
The guidelines also set specific, though personalized, targets, like aiming for an HbA1c that's the long-term blood sugar measure under 8% generally, though maybe a bit higher if hypoglycemia, low blood sugar, is a big risk.
Right. Individualize it.
Yes. And blood pressure targets, usually under 14E90, again with flexibility. And LDL cholesterol, the bad kind, needs to be managed down to specific low levels.
And footwear, you mentioned that before.
Critically important, custom therapeutic footwear is recommended for high-risk diabetic patients, those with significant nerve damage, foot deformities, or a prior amputation. Why? Because poorly fitting shoes are a huge, often preventable cause of diabetic foot ulcers. Simple intervention, big impact.
Wow. It really is a comprehensive roadmap, isn't it? These SVS guidelines provide such clarity on diagnosing these complex conditions, making those strategic treatment choices, and emphasizing that crucial long-term care. It really feels like they're designed to ensure you, the patient, get consistent, high-quality care for the best possible results.
It definitely aims for that. And, it brings up a really interesting point for the future. As medicine and technology keep advancing so quickly, how will these guidelines and the ones that come after keep adapting? How will they integrate all the new evidence, the new techniques to make sure patient care stays truly cutting edge and, importantly, personalized? It really speaks to how dynamic best practices in medicine have to be, always striving to improve.